trying to figure out how to get back to lunch.
She's a
Who?
that young lady
Where?
in the black shirt. I think she's something. She's a
She's going to be next time.
yeah.
Next time. So I want to welcome everybody. This is Stroke Committee. Jane Guerrero's sick, so she couldn't make it here. And I've already done the attendance. I don't see George here, and I don't see Paulina here. No. And first off, Monica Hagues retiring from our committee. And how about this? Better? Okay. I did the roll because I hate doing roll call. Monica Hague is retiring from our committee, and although she's not here, I think all of us want to thank her for her service. And we have this certificate that we're going to be sending her, and she's done a very good job when she helped. So thank you, Monica. Next up is Ron. Can you give us an update on the subcommittee for stroke data collection, just some of the things you've done?
All right. So last committee meeting, we had a wonderful presentation from SETRAC, and they talked about the data points they collected and all the information shared with the hospitals in Houston. And so Dr. Cravens said that he would like to have this information for all of the state of Texas, and so kind of appointed, or I guess gave me the nomination to start collecting data. I've reached out to El Paso, Austin, North Texas, and found out that some of my data from North Texas was shared with the report from Houston, and then finding that not everybody's been forthcoming with sharing information with one another. So they're being more aggressive with it. El Paso just started collecting data within the past couple of months, and Todd Hogden from El Paso shared with me their data points. We've just become more aggressive in North Texas through our RAC and reporting from the hospitals and EMS through Reg-E. So we finally have people doing a better job at reporting all that information. So that's about it in a nutshell. What I was able to pull from the report that SETRAC did, I sent it to y'all electronically, and then the information that was shared from North Texas for that report, I sent it to you as well. So that's all I got.
So, as I remember, some of the tasks that we were going to try to do was try to consolidate, in that there were certain pieces of information that we wanted, and that we were going to collect it here.
Mm-hmm.
And then I guess depending on what the committee thinks, my thought was this is something we should send on to the TCCVDS, the Texas Council of Cardiovascular Disease and Stroke, which does epidemiology at the state level, that then they could use that in making recommendations to the legislature on where appropriate spendings might occur. So I guess the question is, I will try to do better. I guess.
There you go.
I guess the question that I would like to put up for discussion is that something the committee would like to do. Do you want to forward this on? Is that something that you're wanting to do? And do you want to? And is, I guess, also discussion, are there things that we want to firm up as far as data collection? We've done elements before, IV TPA, endovascular cases, and disposition outcome and stuff. Are those, I guess, the two issues are those the things we want to measure, and then are those the things we want to move on?
I think that those are the key points too. Thank you. I think those are key points that we do need to continue to look at, because with that data, we help push the standard of care across the state of Texas, and let people know that this is, what we would like for you to do with regard to the stroke patients.
Other people? discussion? Does anyone want to make that in the form of a motion is what we want to do? Or do you want to give it more time to fester?
You raised your hand. Grab
I'll
your
make a
microphone.
motion that we move forward with it.
I think so too.
Okay, Lisa made the motion, Warren seconded. And the way I'm going to put that is the data elements that we've already requested and that we'll collect them, I guess we'll collect them and then move them on to the TCCVDS. And then the question is frequency, quarterly, annually, semi-annually, annually.
How soon do you have to have your data in, you know, for Reggie and stuff for us in North Texas? 90 days. So I would say quarterly at least.
Public discussion.
Point of question. A lot of our hospitals are already part of having to collect data on stroke core measures, which is now going to be mandatory reporting starting in January, which is a quarterly report. Unfortunately, the Rio Grande Valley did not provide you. We're stroke certified, and we have not provided any information because I didn't know about it. So I apologize for that. I would like to know what other things, other than the indicators that were already mandated to collect data on, this committee would like to see, and then how do we get that to you? Because we're already sending it up to Joint Commission and CMS. So.
Yeah, before this committee voted that the number of patients that were treated with IV TPA, the number of patients that were treated with endovascular care, and then the outcomes, the disposition of the patients, were the things that the committee that we recommended be collected. And I think what's different than some of the other collections, like Get With the Guidelines and stuff, they don't specifically address some of those epidemiological issues. The other problem is in looking at disposition, whether someone goes home or goes to a nursing home or dies, that some people are concerned that may not be a fair reflection on their stroke center or their RAC. Because if you have people who are, if you have a comprehensive stroke center and you're seeing really, really sick people, your statistics might not look as good as some rural hospital that's only seeing very lacunar strokes. But from an epidemiological standpoint or a standpoint from a state standpoint of where resources might be better put, what you want to know is the disposition of patients from a state perspective. That is, how many people are going to a nursing home that we're having to pay Medicare for versus people that are getting better. So I think that's where those numbers, where those things came from, and they're slightly different, I think, than some of the others. The other option is you can look at some of the bigger stroke registries where they're 5, 6, 7 pages, which my belief is they're burdensome on hospitals and other people. Burdensome, difficult. Is there other discussion? I mean, this is not, yeah.
I have a question. When you pull some of the data, do you also collect, for those stroke coordinators, do you also collect when EMS has been activated to the hospital to, so that there's some connection from EMS in the field to the facility? Is that ever part of the data that's collected? So I think that would be very important also as we're looking at EMS systems and how we integrate stroke care in different facilities, statewide, is also starting to look at that EMS component, start putting the finger on that to see how many of those patients that are coming in are coming from EMS, how many are being activated by EMS, so that we can start looking at the educational component, but also validating what's going on with the stroke plans and the RACs. That's just one other point I would think that we would like to look at. If that data is already out there, I don't want to make it too onerous and make people chase a rabbit that's not there. But if it's there, I would also like to see that come out. I think that would be very helpful on the epidemiological side as well.
Any other discussion? Well, I think this is still, I mean, it's a moving target, but if you want to, so the motion on the floor was for this committee to collect from the racks on a quarterly basis the 3 indicators that we had previously asked for and to move them on to TCCVDS. That does not, because this isn't a rule or anything like that, this is voluntary. This could be changed at any time as well. If it doesn't work out, we can do this as an experiment. But that's the motion. And so if is there any other discussion? Okay, so as a work in progress, those in favor of that motion? And those opposed? Okay, so we'll make that as a motion. Next up is a subcommittee report on the work group for input on the Texas EMS Stroke Education Program. So, Homer, can you update us on how that's moving along?
I think the important thing to keep in mind, we have made the recommendations of the types of things we would like to have and the amount of hours. The process of getting it implemented and getting it in the requirements is going to take some time. It's not going to be a real, Emily, am I way off on that? Jane and I had been talking, but she's of course not here. But it's not a thing that we'll recommend and it'll happen next week or next month. It's going to be a timely process, but it will. It's been presented to them and it will be worked into the CE requirements for EMS. And I don't know. I have never been given an approximate time that might happen, but it's could be a year or two, you know, to get into the cycle, because we're actually changing up the CE requirements, and it's not something you just pencil in and change overnight. So it's moving forward. It's just going to be a slow process, but it will happen, and when it does, it's going to be effective, and all our EMS folks will be able to get some stroke CEs that we haven't had before.
Hey, is this written down? Is this something that we can share with other people? How much is it on paper?
Yes, I would like to kind of reconstruct it and make it a little more plain and simplified. But yes, we can do that. That's not a problem.
So, if I could ask, why don't we put pencil to paper for next time, so that we can share that and get input from so we can share it and get input from everybody to see, especially if it's going to be like a 1 or 2 year process.
Okay. Our next meeting, I'll have it.
Okay, let me back up because I forgot to congratulate some people. I guess I could wait. Next up is the liaison reports, and from the other committees. Did anyone go to the cardiac care committee? No. How about the medical directors committee? Did any of you go to that?
I think you've got a couple of notes.
Yeah, please tell us.
In the medical directors, the relationships with the Texas Medical Board are strengthening. There's becoming more cooperation and interactivity between the group, the Texas Medical Board, and DSHS and our physicians that are in the medical directors' jobs. And actually, the Texas Medical Board appears to be very excited about getting on board and helping have input and so forth. The medical directors they would be looking for a position statement on non-traditional transports from freestanding EDs. They were going to have a position statement on regarding EMS students and their clinical rotations. And that's the direction they want to go, is to get that out where they have a stance.
Okay, and Air Medical Committee, anybody go to that? No. Trauma Systems Committee, and the Disaster Committee. I'm going to go to that. And we're all here in the Stroke Committee. Okay. Please.
Christine Newhouse, I sit on the Cardiac Care Committee. I can give you a real short update. There's two things that probably correlate with the stroke and what's going on in cardiac and stroke right now. And the Cardiac Care Committee is requesting a collaborative type relationship with the Texas Centers for CV, I think it's called CV disease. It's another committee that sits outside of our committees, right? And so we've got 3 volunteers from the Cardiac Committee to sit also on that committee so that our efforts are more synergistic. And part of that committee also pertains a lot to the Stroke Committee. So if you guys would like also to participate in a more collaborative on that, I think that would be a very synergistic proposition for the Stroke Committee. And then the other update is that there was a survey sent out to the RACs that came out, and the participation was less than optimal on the survey. It had stroke data questions on there, and it also had cardiac. We have asked to go ahead and resubmit that, and we have asked DSHS if we can go ahead and resubmit the survey. And one of the requests when we do resubmit the survey is to separate out the stroke and the cardiac data points. So just food for thought for you guys.
Thanks. And FYI, I'm on the Texas Council of Cardiovascular Disease and Stroke. I'm the vice chair.
We get representation.
Yeah, we have some representation. Maybe sleep at the wheel. Next up is update on comprehensive stroke centers, and Jane isn't here, but I can give you some of that. Congratulations goes to Methodist Hospital in Houston. If you guys don't know, they're the first comprehensive stroke center certified in Texas and possibly the United States. They were certified by DNV, and so that's very exciting. Looking at comprehensive stroke centers, there are probably approximately 12 that will be certified in the state, and they're all in various degrees of moving forward with that. Looking at the comprehensive stroke centers, there are going to probably be about 12 or 15 of those. There are about going to be 70 or 80 primary stroke centers, and currently we have about 4 or 5 support stroke facilities. And one of the things that we may want to talk about a little later is the level 3 support stroke facilities. In that, just sort of FYI, Kansas has done a thing where they're doing stroke ready hospital certification, which is sort of equivalent to a level 3. And I guess the question is, in that we've only had moderate success with our level 3 certification, is that something you guys want to look at?
I know on the stroke support center certification or designation process, it didn't take off as quickly as everybody had thought it would, but the centers had to prepare themselves. They had to get the data ready. I know there's 3 support centers designated in the state of Texas now. I know there are 3 more waiting to be. So that process is slowly taking off and slowly beginning to begin to increase in numbers, and a lot of it was getting the protocols in place, getting their numbers in place, and getting their program ready for survey. So I think that it will increase more within 2013.
Okay, and what about rural and frontier areas? I mean, if you look at West Texas, you know, after you get past the hill country, there are many, many hospitals out there that don't have any certification. And what do you think about those?
Well, possibly from in the Panhandle region. I know in my rec we have 13 hospitals, and really, they're doing it now. In other words, it's a non-competitive market, so there's really unfortunately, no advantage to spending the money to become a stroke support center. I don't know how the Kansas folks do it up there, if it's a fee-based type system like it is here, but really they're the only game in town anyway. In a non-competitive market, that's where the ambulance is going to go. So we do our best to get out and educate those guys and help them with their stroke readiness and their education based out of our primary stroke center. And if that's all we can do, that's all they're going to do. Money's very, very tight, very marginal hospitals out there in far West Texas.
Yeah. Okay, so it's something we might want to look at in the future, but I don't hear any motion to move forward on that right now. So next up was going to be a presentation from Jim Grotta. He wanted to discuss bypass protocols. As you guys know, this committee has made a recommendation that the transport protocols be 15 minutes. That is, the state rule, the state law is that EMS is to go to the highest level of stroke center based on a bypass plan that is created by the RAC, and our recommendation is that bypass be 15 minutes. Jim believes and wanted to present to us, and I'll leave him to do this at the next meeting, that we might be able to nuance this in that based on the degree or level of the stroke that's happening, you might want to send the most severe strokes to the comprehensive stroke centers, and the lesser strokes would be okay to stay at the primary stroke centers. So it's an interesting concept. There's a paper that's going to be coming out in Stroke to discuss this. It is certainly within our purview to make recommendations or have more than one recommendation on how a RAC can do their transport plan. There are some transport plans, people have talked about 20 minutes to the highest level based on traffic, or 30 minutes. And so I'm going to leave that for next time, unless someone has some discussion they want to talk about it a little bit now. Oh, and the reason Dr. Grotta couldn't be here is his elderly mother sort of got wiped out in the hurricane, and she's in her late 80s, I think, and had no power, no heat, and so he had to go rescue her. So he has a good excuse. So that's all the agenda items that we have. Before I open this up into general public comment, I wanted to congratulate the American Heart Association. For those of you who don't know, they have changed their recommendation on first responders to now go with FAST, face, arm, speech, time to call 911, which is something that we've did here 7 years ago, I guess. And so I think that's good, because I could never remember get with the guidelines. So I'm really glad that that's been changed. And I'm even more glad that it's something that has been our recommendation for a long time. So that opens us up to general public comments. Does anyone have a public comment that they want to bring up? Excellent.
Justin Boyd. Currently chair of the RAC-A, also sit on the EMS committee. You were discussing bypass protocols and placing them in the RAC. I would ask and get some food for thought on when you start talking about bypass protocols. I heard you say something about traffic patterns. You might want to look at parts of West Texas. You might want to look at distance, mileage between facilities. There's not a whole lot of opportunity. There's not a whole lot of demand in our part of the world when you talk about whether hospitals want to participate in becoming a stroke center or not, but you might want to look at that. You might also kick that to the EMS committee and ask them their thoughts and their input on that too, because while in the big cities we understand there are traffic issues, when you get out into rural and frontier areas, you start addressing mileage issues, 100 miles, 150 miles in between a facility and a stroke center. So that's just something to think about.
Yeah, I think that's an excellent point, and I think that's one of the strengths of our the current rules. And that's why we have a RAC-centric stroke policy, that individual RACs, depending on their situation, if they're urban, rural, or frontier, that each RAC is required to develop their own transport plan. And it's going to be different if you're in Lubbock versus downtown Houston. And what's different is, if you're in a rural area, you may not have anyone who's designated or certified, whereas in an urban area, you're going to have different certifications, and so the bypasses may be different. But the other thing you can think about in a rural area where a RAC that has less stuff, you can also have transport plans that use air medical to go to comprehensive stroke centers as well. And then the other thing we talked about is that this committee may at some time want to make recommendations to the state legislature on teleneurology, because teleneurology isn't always available in places, and maybe we can change that as well. Anyway, excellent suggestion. Any more public comments?
Christine Reeves, a Hot Rack out of Waco. 2 comments. One, clarification on Methodist. Have they only received their certification from DMV, or have they already been designated in Texas also?
They've been certified, and I believe they've applied for designation. Jane's not here, so I don't know if they've gotten it.
Okay, I just want to make sure my notes back to my group say the right wording.
Yeah, certified.
Thank you. Number 2 is Waco's smack dab in the middle of Texas, but Waco, the county it's in, are surrounded by very rural counties, less than 20,000 population, and we have 1 hospital in most of them, and so we have stroke capable. They don't have a reason to go for certification as support, so I'm not sure if we can find an in-between for those areas, because even though we're not in the Panhandle or West Texas, we have the exact same issue. We do have transport plans and we send to our primary stroke centers, but we do not bypass the local hospital in a rural facility unless we're flying them air. And if they're over the 8 hours, they're going to the local facility and they're continuing their normal rehab patterns and such. So I don't want to leave those facilities out that are doing the work. They just don't, if the funding coming in and the designation and to keep the designation level criteria has been a little bit difficult for them. So
Do they do drip and ship?
Some of the facilities do.
Cool.
It depends on the EMS agency that's in the county if they're comfortable transporting a patient that's already got TPA on board.
And do you do teleneurology, or is it the ER physician or others?
So one of my primary stroke center people is here, so Eileen.
Yes, it could be either one contract that you do, or they can talk to neurologists.
Well, I think this is a great example of how each RAC has to develop its own transport plan to make it work. Excellent. Beverly.
Beverly Welch, I'm from RAC-N, and I would encourage the critical access hospitals, the rural medicine, to go back and look and see that going for the support stroke center absolutely does. You do get a return on your investment. You see a decrease in your length of stay. You also see a billing process for TPA that you never saw in the past because we weren't doing it. And so once you bring them up to the level of being able to assess the patient appropriately for stroke, then you get more comfortable giving TPA, which gives you that CPT procedure charge. So I absolutely can differ with anyone on that because I have 3 critical access hospitals that assist with that. The other thing is we were talking about the length of stay and how you can turn around a return on your investment. You absolutely is proven now that we're 2 years into it that a designated stroke center absolutely does have a lower length of stay for their stroke patients than a non-designated stroke center. So if you look at the big financial picture, you can definitely justify that money you spend on being surveyed by our state or even by a joint commission, because you can turn that money around in about a quarter or 6 months max.
Excellent. So more money, decreased length of stay, and the cost turnaround is 6 months. Very cool. Other public comments? Nope. Announcements? Any announcements?
Yes, Dr. English.
Ah.
Good afternoon. Emily Parsons with DSHS, and we are actually have a request of the committee from Trauma Systems Committee. In August, at the August GTEC meetings, the Trauma Systems Committee requested the opportunity to create a trauma registry committee registry work group. So this would be an additional work group in addition to the RSWG, the Registry Solutions work group. And so we need one representative from each GTAC committee to sit on that committee, including one from the stroke committee. And they want to start this in February, the February GTAC, and the people that, I should say the person that you select would need to attend the quarterly GTAC, would need to meet with the group who's concurrently going to meet during the GTAC meetings quarterly. And I'll just read you their short-term goals so you have a sense of the scope of what the person would be addressing in the work group. To foster open communication during the implementation phases of the state registry, promote initiatives that assist in that implementation, and provide the state registry with feedback regarding desirable enhancements to the state registry. This group will serve as an information conduit back to their constituents. This group will serve as an information conduit back to their constituents and stakeholder groups regarding the status of the registry. And again, this is going to be 18 seats on the work group, which includes not only the GTAC committee representation, but also the Texas Trauma Coordinators Forum will have a person, and TTAF, as well as 2 DSHS staff. So we can either have you discuss it now, or you can let us know, and that would be Jane or myself, and we'll convey that to Trauma Systems by February.
We got plenty of time. How about Ron? Because I mean, it sort of goes, I mean, I don't mean to task you with it, but this goes along with some of the other stuff you're doing.
I'd be glad to. Just email me and let me know when I need to be there.
Is anybody else interested? And there's no moratorium on us sending 2 people, correct?
Yeah, she said one.
Just one?
We just need, just one, please.
Be a backup, just one.
Okay, Ron.
So Ronnie's your selection?
Yeah, Ron and backup Warren.
Okay. All right, thank you.
The reason I thought Ron was because he was doing the other registry. Okay. Any other announcements? Any other discussion? I was going to wait that for next week.
Maybe I'm out of line. Does anybody else on the committee see, after some discussion we've had today for things that we've been brought up from the Lubbock area and different places around the state? I hate surveys, but would we benefit from a survey? I'm sorry. Would we benefit from a survey that is directed basically at stroke and identifies some of the problems that maybe questions some of the problems that we're seeing? Why are we not doing it? It doesn't pay. I don't have time. I don't want to. I don't know that they would answer that, but it seems like it'd be interesting to find out what's going on around in the form of a survey to folks, to EMS and hospitals. I realize with the luck that some folks have had with surveys, we may not get a whole lot of response, but I think every little bit helps. And it kind of seems a little bit that some of the information is kind of, some things that are brought out. Maybe we should be looking at a little wider scope and ask some questions and get some input.
Could TTAF handle some of that? TTAF?
Or actually, I mean, what we could do, sorry about this. I think the issue, and I would like to hear public discussion on this, the issue with the last survey was it was fairly long, and took a lot of time for people. And a lot of people out at the racks, it's not like, I mean, it's not that they're not interested, but my feeling is they don't have that much time. But I think short surveys, like a Survey Monkey, something online that would be really quick, like 4 or 5 questions, and is not, you know, every week or something, I would, my guess would be that that would be something that people would be more amenable to. What does the audience think? Stuff along that line.
Would you answer it if we send it out?
If it's short.
Yeah, I agree. I
like
think the
three
Survey Monkey thing
questions.
is a great way, and I don't think we need to try to obtain a ton of information. I think it's just some basic things of why do we only have some information that could help us answer the question why we only have, you know, a few support stroke groups. Why don't we have? Why aren't these little hospitals getting involved? What would it take? What could we do to make that work? Just a few questions. I agree that were directed, and then if we needed to do another one later on, if it opened up some areas we're, you know, hadn't seen or hadn't thought about, then yeah, I think that would be great.
Yeah. So Beverly, discussion.
So just from the ground up, really, the level 3s pretty much started with nothing. So it's taken a long time, and we've been working on it even before the rules were approved and just now getting applications in. So that everyone understands, when you start from nothing, you have to get classes, you have to do training, you got to get a medical director, you got to get a stroke coordinator, you got to get someone that's buying in, you got to take it to administration, it's got to get budgeted. So by the time you're done with your journey, you're 2 years into even applying. So I think the fact that we've even had any go through the survey already, that we have the stroke surveyors in place, I think y'all have done a bang-up job. There's nothing wrong with taking your time and doing it right, but when you start with nothing, you have a long ways to go. In critical access hospitals, when we talk about level 3s, a lot of that is what it is. You truly started at the ground level, and you had to build the program. When you start looking at charts, you start doing a PI program, you start doing all these things, it takes a long time, and you don't really want to turn your survey in until you have your program together. So just those little steps take a while to get into place.
I think people need to realize the trauma system wasn't created overnight either. So neither will stroke. I think we're seeing an increase in the participation and the interest in it, and I think it will continue to grow, especially since beginning in January we have to submit data to CMS, so that's getting everyone's attention also. But it does take a while to build a program.
I think today they gave a presentation at Trauma on the 20 years of trauma. I think you're on a fast track with the stroke program. Y'all may not realize it, and everybody's feeling it, but I think you truly are. And those of us that started when trauma started, we know how long it takes to get things going. Your EMS your EMS transport protocols, all that, it took a year. It took a year to get through RAC, and you're part of that plan. So it's just, everybody needs to be patient and be happy that we're all moving forward, and we can see a difference in lives we're saving. So please don't stop doing what we're doing. We need to keep moving and just plugging forward.
If I can redirect the discussion a little bit, with your permission, I think what you brought up was doing some separate small surveys, not necessarily specifically for support stroke facilities. Was that your idea? Is that something you'd be willing to head a subcommittee on?
Sure. I think
so my thought is, and we'll vote on it, but I mean, something like, the last thing we need to do is start burdening RACs with a lot of extra work and stuff. It would be, maybe the first survey would just be what things can we do to make their life easier. And I know that's give them money, how much money they need. But we could certainly, we could certainly do something along those lines. Thoughts?
I think that'd be great. I think we could probably, several of us here could probably work together on a SurveyMonkey type survey that was pretty simple and that we could send out without having to you know, go to TTAF or whatever or whoever. I think we could do something we could do ourselves just to get us some information to you know, to move forward with. And I mean, I think that'd be great. And some of the other guys, Warren, Ronnie, Deb, anybody, but that we could draw up some pretty simple questions created and then send it out. I know if at IRAC, if we get a request for something, we send it out to all our shareholders and let them get it by email and say, hey, would you guys please answer it and send it back? And you know, maybe the RACs would help us do that, or you know, the other sources or places we could get contact information. So.
Hi, how are y'all?
Hi.
I'm Brenda with TTAP. How are you? I think that we would be happy, TTAP will be happy to do a survey for you. I just want you to kind of determine what it is that you want and who's your audience. If we're going to approach the smaller facilities, then it should probably go directly to them and let them help us help them out. But I want to echo some of Bev's comments and Lisa's. I think we are really moving forward pretty quickly, and we're seeing more and more participants in the stroke symposium courses. They're coming in to learn. And I think that we've seen some critical access come on board. We've got some surveys coming up, and I think that 2013 will be more. But I also want to add one comment, that in the smaller hospitals, what we are seeing is that the trauma coordinators are being tasked with also being the stroke coordinators. And some of it is just not enough hours in the day to get all the programs in place. So we just have to be mindful that it's going to take some time. And Bev's right, it takes a good 2 years to build a program. I'm sure you all agree with that. So we just need to be patient and allow this program to roll out. But we'll be happy to help you with the survey. Happy to do it.
So other discussion, please.
Hi, Wanda Helgeson from El Paso. I think we applaud your desire to take a snapshot of where you've come and provide direction where you want to go, and the RACs, I think, are very willing to help you do that. I would disagree about going directly to the small facilities because they look to the RACs for guidance, and I think we could probably help gather that data for you. I would suggest a couple things. I don't think I would piecemeal them. A survey here and a survey there. I think I would take the time to construct a survey that asks all the questions you want to know, and I would encourage that you have other people look at the questions. When you write something, it says what you want to say because you know what you want to say, and somebody else reads it and goes, what? That happened with the last survey. One of the questions was, do you have protocols that for X, Y, and Z? Well, in our area, we call them guidelines, so we answered no. Well, that doesn't, when I compared that to what other RACs had and reported as protocols, then yes, we had those. So words make a difference when you're asking those things. So those would be my suggestions to you.
Those are great suggestions. Other suggestions? Remy.
Hi, Remy Morris, Citizen. I'd like to bounce off of some of those comments, have a directory or a dictionary so that the words will mean the same, so that you are talking the same language. I actually was the one that wrote that survey, and I needed to answer one of the questions, or feel that I need to justify one of the questions that was in there, and it was the one about financing. How do you get your financing? I don't remember the exact question, but the thought was, I was at the Department of State Health Services during writing that, and we were not on the trauma side, but on the prevention side, and we were trying to figure out ways to funnel money to the RACs, so that's why that question was in there. Also, I would like to see Beverly put together, or request or put out in the air, Beverly put together a price package argument for the legislation, or get a paper written on it or somehow, so that we can go to the legislation and saying that this, if we do become, or if a small facility becomes a stroke support center, then this is the reason why. So just marrying a couple things together, and then having funds go to the RACs so that they can support the acute stroke full-time position and not have it be on the trauma coordinator's head. I know that that's a lot to ask, but I think those are some of the things that we need to strive for. And I know we kind of are, but I'd just like to say it verbally. Thanks.
So these are great discussion items. And what I'm taking home from that is that we are interested in maybe doing surveys, but that we should look carefully at the questions. We probably should direct them more towards the RACs and the small hospitals, and that we should review them. Is that sort of summarizing it for people? Is this a subcommittee this group wants to make to do? Those for this? Yes? Any against this? And Homer, will you be the, since you were the one to bring it up? So, and Warren seconds it. And if I could task you, I think what we should do is maybe work on some questions first, and then bring them back to vet here, and then we can then determine, the method of sending them out, something like SurveyMonkey or something. And then, it's not something we necessarily want to dump on TTAF, although it's very nice that they volunteer. It may be something we could do ourselves or something that DSH could do. We could also look at that at the same time. Thoughts?
We'll involve TTAF on that
Yeah.
conference call on the planning. Yeah. I think they're very, very important. They are the link.
Well, and it might be that it might be a survey of TTAF, of all the people in TTAF. It could be, it doesn't have, it could be, we could do surveys directed at RACs, we could do surveys directed at hospitals, we could do surveys directed at TTAF or personnel. It doesn't have to be, you could start an initiative how you want. Yeah. This is great. So anything else? If not, this will be a short meeting. I apologize for Jane not being here because I don't have the time for the next meeting, but we'll update you on that when it comes. And other than that, I'd like to move for adjournment. Good. And we're adjourned. Thank you very much.